I'm Dr. Randall Feingold of New York Breast Reconstruction and Aesthetic Plastic Surgery in Great Neck, New York, and Director of Plastic Surgery at St. Francis Hospital in Roslyn. Today's topic is breast cancer screening guidelines for individuals who are considered at high risk for developing breast cancer. Helping us today are three expert panelists that I'd like to introduce. First, Erica Poole, Certified Genetic Counselor at St. Francis Hospital in Roslyn.
Thanks for having me.
Dr. George Autz, Breast Imaging Radiologist at Complete Women's Imaging in Garden City.
Thank you. Pleasure to be here.
And Dr. Marie Chen, Breast Surgeon in Greenvale and Director of the Breast Surgery Service at St. Francis Hospital.
Thank you for having me. Great to be here. Thank you.
I'd like to start with Erica, and I was hoping you can help our audience understand the risks of breast cancer in general and how it's different for people with high risk factors. So what is the baseline risk of breast cancer in the population, and at what ages does this typically occur?
Yeah, so the baseline risk for the average woman is estimated to be about 12% lifetime risk. So we all have a risk for developing cancer as we get older. That's just kind of a part of being human in general. And so what it is that we do is around the age of 40, we do make those recommendations for all women to start breast cancer screening because that's where it is that we're looking at, okay, let's go ahead and start taking care of this and kind of just managing a little bit more because 1 out of 8 women are at risk for developing breast cancer.
And that may be true for the population in general, but there are people that are considered high risk. Who is considered high risk?
So there are people that have mutations that might indicate them to have a higher risk than the average population. So mutations such as BRCA1 and BRCA2. There's some other genes as well, like PALB2, TP53. And for those individuals, we definitely want to alter that breast cancer screening age of starting time. Typically, we would start around the age of 25 to 30, depending on which gene and risk factors that we're including in that. For individuals, say, that just have a family history of cancer and maybe a gene mutation cannot be identified, then we kind of look at the family history to see what type of cancers are in their family. Are there young breast cancers in the family history? And then we would make those recommendations about 5 to 10 years prior to the youngest breast cancer, if it's younger than the age of 40 that we recommend for everybody.
So you said the lifetime risk of breast cancer in general is 12%. What is the elevated risk of breast cancer in people with these mutations? And is it different whether they have BRCA1 or BRCA2 or just a strong family history?
Absolutely. Yes, it is a little bit different. With BRCA1 and BRCA2, or BRCA1 and BRCA2, we kind of put them together and they say that it's greater than a lifetime risk of 60%. So that's where it is that we would be talking about altered screening options, more frequent screening, earlier screening. And then there's some other genes where it is that we would make recommendations, say that they're 40 to 60% lifetime risk or 20 to 60 lifetime percent risk in general. And so those are the numbers that we're working with when it is that we can identify a specific reason and a specific cause, saying this right here is the reason why we're adjusting this screening, why we are looking at this additional screening in general. And then sometimes, as you mentioned, we have family history where it is that we're seeing increased risk for breast cancer. We're seeing multiple breast cancers in the family history. Maybe we're seeing younger breast cancers than, say, the age of 50. And that's what it is that we would also take into consideration with that, of when to start screening, and also too as in how frequently and the types of screening that we would recommend based off of that family history as well.
So you said greater than 60% risk. That's a very high number. Does that mean someone has 60% risk when they're 20 years old or 30 years old? At what age does this elevated risk seem to begin or appear?
So it's definitely increasing up to that greater than 60. We would not say that a 25-year-old has a 60% lifetime risk to develop breast cancer. But what it is that we are usually seeing is that we see younger breast cancers, which is why it is that we start at age 25 for those breast cancer screens. So it's kind of like we're approaching the number of greater than 60 as we get older, but also too, the longer that a woman lives without developing this disease, her risk is also going to be adjusted. So it's kind of this combination of statistics of what it is that we're looking at to kind of make those estimates.
So, if a family has a strong history of breast cancer or a known gene mutation, how do you counsel a family that has, say, teenage girls? What do we tell them?
So we would start wanting to just kind of make their family members aware, or their teenage girls aware, teaching them what it is that self breast exams could look like. Usually that's starting around the age of 18 in general, but it can be altered because it's never too early to start talking about women's bodies and kind of what it is that they're getting used to and what it is that they're growing into as well. So those are elements that we would start talking about with them. But we wouldn't necessarily, if there is a mutation that is identified, we wouldn't necessarily recommend testing until the age of 18 because we would want to make sure that that individual has choice in deciding whether or not that they want to know this information, because sometimes people are not interested in knowing if they're at elevated risk for breast cancer. And then we would just kind of screen them as though they are at higher risk for developing breast cancer in their lifetime if they chose not to have testing.
So, you don't really recommend testing young family members until they're 18 years or older. And when would you begin screening examinations by a radiologist? At what age?
Correct. We look at these conditions being adult onset, so there really isn't a need to have a 7-year-old know that they might be at a higher risk to develop breast cancer much later in their lifetime. Absolutely. With it kind of depends on which type of mutation and if one is identified. So for BRCA mutations, for example, we start doing a breast MRI at the age of 25 annually. And then at the age of 30, we would make that adjustment and also add a breast or a mammogram at the age of 30 on an annual basis as well. And then we would stagger it between the annual MRI, and we would split between every 6 months.
So, just to summarize your comments and recommendations, the baseline risk in the population is 12%, but the high risk population is greater than 60% over a lifetime. And testing a young person for a gene mutation would be considered after the age of 18, and imaging studies perhaps around the age of 25.
Absolutely.
Right. So I guess this would be a good time to talk with Dr. Autz about how we actually screen people for breast cancer with regard to breast imaging. Dr. Autz, I think there's a little bit of confusion out there about ultrasounds versus mammograms versus MRIs.
Right.
How do you view these different modalities in terms of their relevance to breast cancer screening? And is any one of these modalities more helpful?
Well, yes. First off, we still use screening mammography as our main imaging study in looking for early breast cancer. So that's going to be our main technique that we use in virtually all protocols with rare exceptions. The screening mammogram nowadays, remember, is typically a digital mammogram study with something called breast tomosynthesis, often what people refer to as 3D mammography. But there are other screening tests, as you mentioned, including breast ultrasound, which is the most common second test to be used. We typically will use breast ultrasound as a supplement to the screening mammogram study, especially in patients with dense breast tissue. That's because we know that the dense breast tissue that exists in a lot of women can actually mask or hide small cancers. And the best way then to identify them may be a combination of the mammogram and the breast ultrasound study. The third primary screening tool that we have is breast MRI, which we usually reserve for high-risk patients. And also we often will use it in patients who are newly diagnosed with breast cancer. Breast MRI is a little bit more involved. It involves IV contrast called gadolinium. But we certainly use the breast MRI, as Erica alluded to, in our high-risk patients. Typically, we will define high-risk patients as greater than 20% lifetime risk, cumulative lifetime risk. And most of them will be getting breast MRI, either starting at a very young age, such as the BRCA1, BRCA2 patients who have a gene mutation in BRCA1, BRCA2, or in some of the other patients who have other gene mutations as well.
So a lot of younger patients are concerned about having imaging. They're worried about radiation to their breasts. They're confused about whether MRI has radiation. Can you comment on this?
Sure. First, in terms of the mammogram study, it is an X-ray examination, so it does have a low dose exposure. Most people don't realize that we all get background radiation every day as we go through living. There are many things that can increase radiation exposure, including hiking into the mountains, flying on airplanes, etc. The background radiation of a typical mammogram study is about equivalent to about 7 weeks of background radiation. Breast ultrasound does not have any radiation. It uses sound waves. Breast MRI also does not have any radiation exposure at all because it's using something called magnetism. We have a lot of respect for the radiation exposure using mammography, since women will be undergoing mammographic studies for many, many years. When I first started this 30 years ago, I thought, oh, mammography may not be around in 30 years, and yet here it is. And it's not going away anytime soon. So we try not to expose women, certainly not under 30. As Erica alluded to, for patients with the BRCA1, BRCA2 mutation, we add on mammography at age 30. In general, I try not to use mammography under age 35, but I have no trouble using mammography yearly from 35 to 40 if patients are at an elevated risk. And certainly we have no issues then at all, starting the screening protocol a little bit earlier with mammography.
Is MRI the most effective screening tool?
MRI is definitely the most effective screening tool in patients at high risk. There is no question that it has a much higher cancer detection rate in that population. It is less certain how effective MRI is in terms of patients at moderate risk, which we define as patients with a lifetime risk between 15 and 20%. And there really are not any studies looking with breast MRI at patients at average risk and how effective it is. In the future, people are hoping that there can be abbreviated MRI studies and also MRI studies that may not eventually use contrast, which can then make it a better screening tool for average risk patients.
Is there a specific risk associated with using contrast with MRIs?
The risk associated with gadolinium is very, very low. There has been studies which show that gadolinium, because it is a heavy metal, can deposit in different breast tissues, including in the brain, the liver, and a few other areas. We're always cautious with any kind of IV contrast. Matter of fact, gadolinium is delivered based on renal function and also total body weight. So whenever it is used, it's only the smallest amount to be effective that is of use. In general, though, it is a very, very low risk contrast medium.
How frequently should individuals who are at high risk for developing breast cancer get their screening imaging studies? Is it once a year or more frequently?
Usually it will be once a year, but we may stagger it, especially when we add breast MRI. So a common protocol would be to do a mammogram and possibly with the breast ultrasound once a year. And then if that patient also deserves breast MRI as a screening tool, we'll usually try to stagger that by 6 months. Part of that is because the patients who are at high risk often are nervous about this. You know, they feel sometimes that they have something hanging over their head. They feel like they're going to definitely get breast cancer, and they appreciate the fact that every 6 months they're being looked at. So that protocol of once a year mammogram and sonogram, and then 6 months later, breast MRI, and then mammogram, sonogram again 6 months after that, is a very typical protocol, very much accepted by high-risk patients.
So you would start imaging in the mid-20s and do this staggered protocol indefinitely?
Yeah, we would start breast MRI, as Erica mentioned, in the mid-20s, usually age 25. We do not use mammography under age 30 in the patients with a BRCA mutation. Patients who only have family history of breast cancer and at high risk, we do not start at 25. Usually we'll start breast MRI later for them, depending on certain circumstances. But it's the patients who have a known mutation, BRCA1, BRCA2, who we definitely start at age 25. There is another population of patients, and those are the patients who were treated with mantle radiation therapy at a young age for Hodgkin's lymphoma. They are also at a very high risk. Matter of fact, very similar to the BRCA, to the patients with a BRCA1, BRCA2 mutation. So they also will start at age 25 with breast MRI only.
Great, that's really excellent information. So we've heard from Erica Poole about the risks of breast cancer and who's at higher risk. We heard from Dr. Autz about how we screen for breast cancer. Now we're going to talk with Dr. Chen about surgical management, because Dr. Chen, there is a difference between preventing a cancer and treating a breast cancer, correct?
Yes, definitely. So for the BRCA patients, the risk is high enough that the ultimate goal is preventative surgery. So what I mean by that is it's a bilateral mastectomy with immediate reconstruction before the development of this condition. If surgery can be performed before the cancer develops, then surgery and recovery is the end of the road. However, if the cancer develops first, then surgery is only the beginning of the road. And then other treatment modalities, such as chemotherapy and radiation, would follow. So the surgery is the same, but to me, the timing of the surgery is important. Again, if surgery and recovery can be the end of the road, I think that's the best for the patient.
You know, that's a great analogy about end of the road versus the road beginning. But when might a young woman consider preventative surgery? What's the right age?
So that's a question that I get a lot. So regarding the timing of the prophylactic surgery, there's no formal recommendation by what age the mastectomy should be performed, which is very different from the recommendation for when the ovaries need to be removed in a BRCA patient. So what I explain to the patient, it's a little bit of a cop-out answer, but I say it's just before the cancer actually develops. But can we predict when? It's very hard. If there is a family history, I will look at the age. So, for example, if a patient test is positive and her mother is also positive, I will try to see what age the mother was diagnosed, because maybe that's an indication as to when the patient might develop breast cancer. But there's no specific formal timing regarding age for the timing of the prophylactic mastectomy.
So it's useful to know when other family members have developed a breast cancer, because that might sort of establish a precedent of when concern will rise. But what's the youngest age you've seen a woman develop breast cancer?
Who actually developed breast cancer?
Mhm.
23. So that's the youngest.
So I can see that that must generate a fair amount of anxiety within these families about knowing when to intervene.
Yes, definitely. And given that we don't have a set recommendation, that can sometimes be very difficult for patients. Um, but usually somebody in their mid-20s, even if they carry the gene, will not typically develop breast cancer in that age group. So for the younger patients, I do recommend surveillance over surgery. I have certainly done prophylactic mastectomies in the mid 20 to early 30s. That's usually at the patient's initiative rather than that being my formal recommendation. In that the younger age group, I would recommend increased surveillance, which has already been discussed by Erica and Dr. Autz. So this every 6 month type of follow up.
So, in addition to imaging studies, do you recommend that these women with no symptoms be examined by a breast surgeon every year or every 6 months?
Definitely. So if I have a BRCA patient who is not ready to undergo the prophylactic surgery, I do recommend every 6 month surveillance, which includes a radiologic imaging followed by a breast exam. Not all breast cancers show up on the imaging. There are some subtle findings on a physical exam. So it may not be a mass per se, but it would be like what I call loss of curvature or something that's just not exactly symmetrical. So a physical exam is definitely important in addition to the imaging.
So, let's say a young woman decides she's ready to undergo a preventative operation and she wants to know what exactly is this mastectomy going to be like? Is it the same type of mastectomy that was done years ago? What's the modern approach?
Yeah, so we have definitely come a long way regarding the surgical approaches to a mastectomy. So there are different types of mastectomies. So for a prophylactic mastectomy, for sure, it's what we call a simple mastectomy. And what that means is that the breast tissue is removed, but there's no need to remove any muscle or ribs with this type of surgery. With immediate reconstruction, much of the owns of the patient's native skin as possible, and then that becomes the envelope for the reconstruction. So it covers whatever the reconstruction is going to be. We have even made more progress than that in more recent years, and we now know that we can safely save both the areola and the nipple as well. So really, nothing on the skin is removed. It's all the internal tissue, fat, ligaments, and glands that need to be removed. So if the areola and the nipple are in the correct position, it is possible to save the entire skin, and patients retain all their own areola and the nipple.
Well, if we're keeping the skin and we're keeping the nipple, but we have to get the breast out, where are we making the incision? Is it visible?
We try to make it as invisible as possible. So a very common approach is what we call the inframammary crease incision. So that means it's the very bottom of the breast where the breast kind of folds on itself before it becomes the abdominal skin, and we make the incision there, and it's very inconspicuous.
There's so many great teaching points here, being that we really want to prevent breast cancer, and no matter how early you're identified as a high-risk individual and how regularly you go for your imaging, your physical exams, you are still living with increasing risk as you age unless you have preventative surgery. But at least the preventative surgery is done through hidden incisions, preserves the skin and the nipple, and would really lend itself to high quality reconstruction then.
Definitely.
And I think that's important for especially younger patients who may not be married yet, they may not have children yet, they may be living with anxiety about the risk of developing cancer, but also the anxiety of having an operation that probably in their mind is going to alter their body in a concerning way. So there's certainly a lot to reassure them about. I do want to conclude with a few comments on the breast reconstruction aspect. Breast reconstruction is typically done immediately at the time of mastectomy. The modern mastectomy approach, as described by Dr. Chen, really lends itself to preservation of nipples and imperceptible scars hidden in the crease under the breast. We can restore breast volume either with implants or with natural tissue such as body fat, and that both of these methods produce results that are often indistinguishable in appearance from the original breasts. When body fat is used, it can be transplanted from the lower abdomen or the inner thigh with microsurgery, and it doesn't damage the donor sites, it actually improves their appearance. The latest improvement in breast reconstruction is reattaching nerves to the reconstructed breast to restore sensation after mastectomy. And it's really all of these excellent improvements in the aesthetics and the sensation of breast reconstruction that can help women make a very courageous choice to undergo preventative surgery to maximize their risk reduction, to avoid long-term imaging, and to achieve what my patients describe as both peace of mind and quality of life. I want to say thank you to all of our expert panelists. I really learned a lot from this presentation, and I hope all of you found this to be a great source of information as well.
Thank
We
you.
did. Thank you. Thank you very
very,
much.
very much.
Thanks.
Very good.